My name's Amy. This is Jen. We're both sonographers at the Cleveland Clinic, and so we're representing the sonographer population here. So what we want to cover today will be mostly diastology with Dr. Klein and Dr. Sengupta having conversation about the new guidelines, how we apply them with cases. I do want to show you just one example of how we would do an LA strain case and how easy it is to do LA strain. We know we've talked about the LARs and how important it is to, here comes Dr. Klein running in here because he's so busy all over the place. But so how important it is to have LARs when we're talking about our new diastology guidelines that are coming out, and even our current ones when we have indeterminate data. So I just want to show you how easy it is to do, to encourage your labs to do. I will show you both on TomTech and on EchoPack. They are both, it's a GE and a Philips product. Let's just walk through it real quick, briefly. Like I said, it's all automated, so it literally takes the click of one button and some editing from us, and we're done. So if you guys can go, I have this nice big cursor now for you to see, but this is case 10. LA, and you're going to double click on that. If you need help, just holler. If you're not there, if you don't see it. But we're looking for something that looks like this. Case number 10. This patient, obviously, look at this LA, it's ginormous, right? So they have HFpEF, they have diastolic heart failure. So we expect probably this LA to be big. If we click on it, we can see it moving. Our first step is we want to highlight this to be able to select this to say, hey, we want to do some work on this. So we are going to hit the control button, hold that down, and then left click on that image. So you now see that my image is highlighted in yellow, so I now have selected that image. Once you've done that, we're going to go into EchoPack first. So when you see that little square there, that plugin, we're going to click on EchoPack. And this is the GE product, so it's going to pop up with an EchoPack. It looks very similar to the user face you would have on your cart. So once we have our image up, under Measure, this center tab on the right-hand side, we're going to come down here. AFI is what the strain package is for GE, so there's AFI RV, if we want to do an RV strain. There's an AFI LA. So this means we want to do LA strain. So all I do is I click on that. Of course, it's important to have a good view of your LA. You're not cutting off pulmonary veins, decreased depth. You're not cutting off any part of that. So ideally we want a 4 and a 2 chamber. I'm just going to show you very briefly this 4 chamber because I wanted to make sure we're focusing on diastology a lot here. But we're going to label this as a 4 chamber by clicking on this 4 chamber. It says Select View. I'm clicking on 4 chamber and telling the system it's a 4 chamber view. Now there's an image up here that shows me exactly where to place my point. So if I move my cursor over here, it says this needs to be at the septal base. So I'm going to click right where that mitral annulus, where that leaflet hits that septum. It then changes and says, I want you to put your lateral base on. So I'm now going to identify this as my lateral base. And I like having this cartoon image up here to show me that. And then my last one is the LA roof. So I'm going to come all the way down here into the LA roof, obviously making sure we're not going down into the pulmonary veins or anything crazy like that. And now it's going to draw a contour for us. And I'm going to make sure that it looks like it's the wall of the LA. When I like that and it looks pretty good, I can either not do anything and let it process, or I can just click on the process button. And that's it. It's very simple, very brief. And you're going to see we're looking for the reservoir strain, which is this right here, SR, which is strain reservoir. All right, and that is 14%. So that is how we do strain. We would do a 4 and a 2 chamber, like I mentioned. That would be ideal. But that is how we would do strain and EchoPack. Yes? So the question was, how does mitral annular calcification affect your LA strain?
It shouldn't affect it too much unless you have like a mitral stenosis. So the strain, like a pulmonary vein, can be affected by MAC. So it's more the chamber preceding the mitral stenosis in a way.
Thank you. Good question. Any other questions? And we're going to move on, and I'll just show you how to do it in TomTech, our other software for Philips, and then we'll let them do the rest of the studies here. Okay, so we're going to get out of this. The way we get out of this is we're going to hit up here in the center, there's an Exit tab. We're going to hit Exit. That brings us back to our original study, and we're going to stay in this. Don't get out of this. We have that image selected still. So make sure you have this image selected at the square, that yellow square. If it's unselected for some reason, hit the control button, hold it down, and left click on it again. Once we have this, instead of coming up here and hitting EchoPack, we're going to use this arrow drop down right beneath EchoPack, and we're going to go into TomTech. TomTech, like I mentioned, is the Philips product. If you're on an Epic or some sort of Philips product, you can. This is how you would calculate your LA strain. Okay, I have my image up here now in the top left. Hopefully we're all here. If not, raise your hand. So image up here in the top left, I'm going to left click on that image, and it gives you some choices, right? So if you guys were here yesterday, we did some cropping. That was under that 4D cardio view. We're doing our LA strain, so it actually says auto strain LA. I'm going to select that. And again, I didn't even touch anything, right? You guys didn't touch it. It automatically went ahead and did it for you. So a little bit less steps than the GE. Still very simple with the GE, but again, it gives you your strain value here is 12%. Remember, it's 14% for GE, so pretty similar. That's fine. If you want to edit it, you can go back to tracking revision, and I talk about how it's important to make sure it's accurate. So you can come back in a tracking revision, move things around, make sure you like that it's tracking well, and then go back under analysis. Okay, that's all we're really going to do with these. Any questions about the process of doing LA strain, the technical side of it? We're going to get into a lot more about LA strain throughout the rest of the time. Yeah, that's a good question. It's a common error we see with tracking with LA strain and also with our pulmonary veins when we're tracing our LA volume. So the question was, what do we do with the pulmonary veins? We just kind of pretend like they're not there and go right above them, essentially, if they're open. So if this was a big pulmonary vein sticking here, I wouldn't go down into the pulmonary vein. I would just track right on top of it and going around. And that should solve it. I don't think it does. I haven't seen it mess up. Have you seen it at all? If pulmonary veins are there and present in your image, does it affect your LA strain value at all? Yeah.
So you probably want to avoid the vein. So yeah, but I could. You want to exclude that part.
And typically, it's in the line, so it's not looking at individual segments when they're tracking the LA strain. I can't tell you exactly. I'm not a vendor, but from my understanding, it's the line of the strain. It's not just segments at a time. So I think the total, it will not affect it, in my experience. That might be a good question for the vendors. One
other thing is, while we have this one up, I think in the new guidelines, I think everybody should be doing LA strain. It's so easy to do. It's like GLS. If you're doing GLS for the LV, you might as well get a LARS for the left atrium. Now, whether you interpret it, what's affecting it, that's another issue. But it's so easy to do. As you can see in this curve, you have three values. You have the reservoir strain, 12%. A good cutoff would be around 18%, so this is low. And the conduit function is also very low. It's normally around 10, 12%. This is 2%, 2.8%, so definitely impaired as well. This is also very useful looking at LA after an ablation. After a maze procedure, even after a conversion, this may be useful as well. So I think this is going to be more common. Many things affect this as well, like anything else in cardiology, mitral regurgitation, etc. But very good.
Okay. All right, thanks. So this is what we'll use. I just want to make sure we all can close out of this together. So you'll close out of it on the right-hand corner. And we're going to exit. We don't need to save anything. That's fine. And then we'll just get out of this. This is the TomTech. We'll go again to that right-hand corner and exit out. And then we can go back to the study list in that left-hand corner. And then you'll come back to here. And if you guys want, after that, you just, ta-da, closed.
All right. So just to kind of tie, does everybody hear me there? Tie together the strain tips. Just super quick, a couple slides to make sure everyone's on the same page about how to perform good strain. Of course, we know what LV strain is. It uses the speckle tracking to help us interpret LV function. Keep in mind, I work with a lot of junior sonographers that come into our lab, and they have a lot of questions about strain because if the F is normal or abnormal, they always question what their strain values are and if it's tracking right and everything. But keep in mind what strain is doing for you. It's to help detect early LV dysfunction. So as long as your pattern is tracking well and you've made all the adjustments and your technical parameters have been met, if it's tracking abnormal or giving you an abnormal value, it's supposed to detect underlying dysfunction. So EF and strain aren't always going to match. So that's a very confusing thing for junior sonographers. And also there's been identifiable strain patterns that we've studied and been able to help differentiate HOCM, apical HOCM, our cherry on top, amyloid kind of cases. So there have been identifiable cases as well. Again, I'm just going to move through a couple things. Keep in mind your heart rate variability. Ideally, you want those numbers to be as close as possible. We can see here that this one's 83, 101. A lot of the vendors and systems will just kind of spit out an error at you if you try to track this strain. So I do recommend what we have our sonographers do in the lab is to, and you can see here the sonographer attempted at the same depth and time of the study. That way you have your best, all your sector width is the same, your depth is the same, your settings are the same, and hopefully your heart rate is the same as well, depending on the patient's rhythm. Here again, just illustrating the heartbeat differences and how this strain is just not going to play nice with us. And we'll see here an example of when it was attempted, just the how it just did not like it. So just some really good tips for that is just make sure your good 2D image is not foreshortened, so you're not cutting off the apex. Again, we have different strain patterns for the apex that can appear. So you want a good EKG and image capture. And I did reference, like, if you have heart rate variability, a trick on some of the systems is you can use triplane if it's absolutely necessary to obtain your strain value. If this is a chemo patient or something where it's very critical to their results, you can always attempt triplane and see if that can assist you. Keep in mind your optimal frame rates, of course. Adjust your ROI accordingly. I think that's something that's very underutilized as an adjustment. And then be mindful of the annulus as well. Don't go past the annulus. LA strain, Amy just went over, and it's a very big highlight for us here at the conference about how it's going to be more incorporated and used in our new diastology algorithm. And kind of keep in mind that 18%, that's kind of our number that we want to focus on if it's more greater or less than 18. Amy just went over this, but again, you want to make sure quality images, non-foreshortened. I think a lot of times the LA ends up foreshortened. I think we're very focused on the LV not being foreshortened. Don't cut off your LA as well. And keep in mind ROI for LA counts as well, not just the LV. The LA is a very thin wall chamber, so don't neglect adjusting your ROI here as well. And then be mindful there's other little pathology things that can pop up. You have bowing and mobile intraatrial septums, as Jared asked about pulmonary veins, and then the left atrial appendage can pop in there in and out as well.
Notice the strain curve is basically looks like a pulmonary vein. If you look at the big S wave, the D wave, and the atrial reversal, so it's really very similar to pulmonary vein flow. So those of you who've done pulmonary vein flow for years, let me ask Partho, do you think LA reservoir strain is going to be more accepted in most labs, or is that just another thing to do?
I think the couple of points I wanted to make, I think I wanted to just quickly add that both strain, both LV, LA, have dependency also on load and blood pressure. So we do make sure that we record the blood pressure so as to be able to compare, particularly in patients with chemotherapy and who are coming for serial follow-up. We try to make sure that we keep that into consideration. Coming back to the LA strain, I think what is very critical is, as pointed out, is the foreshortening component. So with the LA remodeling, sometimes you have variations, and the LA may remodel and elongate and may not remodel spherically. So being able to capture all of that is not only important from point of view of volume calculation, but also has implication for the measurement of the strain. And so whenever we want to get any form of strain, there are two things I typically want to say. First, the image quality, so which means that beware of the shortening and foreshortening and information. And number two is do not try to overcorrect a lot of people try to go and overcorrect or stretch, unless until it's, of course, not tracking correctly. The reason is there is an inherent bias you introduce when you're trying to change, and you don't want to change too much. So let it track, and if you're satisfied and if it's on the wall, doing well, just leave it, because then you'll have a standardized way you're measuring it across all your patients. So that is important. Coming back to your point, I think, I believe that LV strain is more easier than LA strain. The only challenges that I sometimes see is the trackability on thinner aspects, sometimes like the interatrial septum or the roof of the LA if it's not clear. So sometimes it does introduce the variability. After the guideline is going to come in, I think we will have to see how much people are going to be able to adopt it. But I do believe that the LV and the LA are coupled together. You know, the mitral annular motion and the reservoir is just the mirror image of the LV. But this relationship gets decoupled with the development of diastolic dysfunction. So there is definitely a lot of information there which can help us to tease out some of these patients. So I think it is important information. The question will be, how do we overcome the variability sometimes that comes with the quality maintenance and all. That will be the only challenge. Yes, atrial fibrillation. So atrial fibrillation will introduce changing RR interval. So with the changing RR interval, you do have the change in the reservoir strain as well, just like GLS. So AFib does introduce a considerable challenge. So in that, I think my opinion is that we'll have to come up with way to rely on AI to do multiple beats in AFib, because you need multiple averaging to get a representative number. If you just do one beat, it is not going to be reliable, because that RR interval it's very dependent on the RR interval. So for that sake, I don't know how much AFib we do, atrial strain, but I think typically we like to do it only when it is reproducible, like in sinus rhythm. I don't know whether you do it in AFib.
AFib would make it more difficult, but just to anybody in academics, if you write a paper in LA strain in any disease, it's going to get published. So I haven't reviewed a paper, but I think on my docket is to review something on strain and mitral valve tear, predicting the outcome. So in other words, there's a the reduced LA strain and mitral valve tear, maybe association. We've done work with the LA strain, for example, in amyloid. Somebody in amyloid and sinus rhythm doing the LA strain pre will predict likely of stroke, thrombus, and thromboembolism. So it's very simple to do. I mean, a lot of things affect it, like pulmonary vein, mitral regurgitation, atrial fibrillation. The biggest determinant of LA strain is LV strain. So they're all interconnected. But very good. Let's move along here. Okay, what's a hot septum? We're in sunny Florida. Is Dr. Klein getting a little heat stroke in his head? What is he talking about? Hot septum. Okay, next case. Okay, so here's a 63-year-old with a history of viral transient constrictive pericarditis. What does transient mean when I say viral transient constrictive pericarditis? Transient means there's constrictive pericarditis, but it's transient meaning that you can probably hit this with anti-inflammatories. It's an inflammatory case. So in other words, you get a viral illness, and so for whatever reason, you're starting to get heart failure, and you're getting some of the features of constriction. Okay. So the patient treatment included anti-inflammatories as well as diuretics, and rilonacept was started and tapered for surgery. So rilonacept is a biologic. Actually, after this session, one of the non-CME involves that biologic. Okay, next. Okay, so here, I know this is a mainly echo, but this MRI tells 1,000 words. This picture tells 1,000 words. So basically, you see that the white halo around that MRI is the late gadolinium enhancement. That tells me that this patient is very, very inflamed. This will take years to get better. And often, if you catch it early, perhaps the anti-inflammatories, but this said that this is a very inflammatory case. Next. Okay, so on echo, you can see the features of the upper left. You can see that there's what you call a septal bounce. And on the right, first of all, the septum, it has a little bit of bounce to it. And there's also, if you sort of time it, the RV is getting a little bit bigger when you inspire. And then an opposite when you inspire, and opposite with expiration. So diastolic septal bounce, respire phasic shift. Some of the features of constriction. Also, in the short axis, you can see the bounce, how the septum, and also inferiorly, you can see that there's a thickened septum. And you can see the appearance of the tethering of some of the walls, of the septal bounce. Next. Okay. So maybe I'll ask Partha. So this is annulus reversus. What does that mean?
So if you see here, you have the lateral annular E prime velocity, which is 14, and the medial is 16. Normally, the lateral E prime velocity is the larger one than the medial one. In this particular instance, how old is this patient, you said? 63. So in general, when someone is 63, a number of 14 and 16 is a large number. I mean, you typically don't, this is a exaggerated motion in general, so velocities are pretty high. But in addition to that, this ventricle has got a check on the lateral side and a free motion on the medial side. So this reversal of the velocity with this exaggerated longitudinal velocity is all consistent with a term called as annular paradoxus seen in constrictive pericarditis.
Okay, so we have the annulus reversus and the low EV prime, 2.9. Normally, as the pressure goes up, the EV prime goes up. That is very, very low. As Dr. Sengupta just mentioned, you get this what you call annulus paradoxus. So there's annulus reversus, that the medial and lateral reversed, but also the extremely low EV prime, 2.9, because the E prime is so high. That's why you got such a low ratio. Next. Pardon me? A normal one would be like 8 to 10 ratio, but this is 2.9, very, very low. So in other words, the E prime is so out of proportionally high, so therefore the ratio. Lateral is the two extremes, the lateral mitroannular lateral, and the tricuspid annuli should be the most. So the most should be, imagine like a cash register. Tricuspid should be very, very dramatic. Also, the lateral mitral should be very dramatic, and septal should be the least. And constriction, the septal is the only one, since the two walls are sort of retained by the thickened pericardium, that's why the septal is so high. Very few conditions will cause that. And here you see the Doppler variation on your far left mitral inflow. And as written on the top, you can see the decrease E wave by 25% can suggest constrictive physiology. But let me ask Jenna about the technique to get such a good tracing. So what do you have to watch for?
That was wonderful. I was gonna mention that, Dr. Klein. I think for a technical tip for sonographers in the crowd, yes, these can be challenging, and it seems like it should be simpler than it is. But respirometer studies can be challenging, and some of the things that I instruct our sonographers to do is taking that box part of the EKG, essentially, that's whichever vendor you're using, and laying it on the patient instead. Like a lot of those wires are hanging, dangling off the bed, or they're any which way. If you lay that box that holds your EKG on the patient, also having good bone contact with your EKG leads. Some people are very wild with their EKG placements, making sure that you're on a bone and not on like a different area where there's a lot of tissue, and just playing around with your respirometer settings. Change your physio leads from 1, 2, 3, wherever you can pull that in best, because especially for your pericardial patients, that respirometer really is a source of a lot of good information for our doctors. So those are just some technical tips. Again, making sure your sample volume is right, that it's placed at the leaflet tips, as we do with all diastology things. But yeah, that it can be tricky, but I really encourage you to move stickers, make sure you're on a bone, and make sure that you do play with your respirometer settings.
Okay, thanks, Rim. Okay, and here's the tricuspid inflow, which is opposite. Usually a 40% decrease in E wave with expiration can suggest constrictive physiology. Next. Here's the left atrial enlargement is large. Next. Nice subconstant view. Notice that septal bounce, and the lower right you can see a long clip with breathing, how the RV and LV are changing with breathing. So this is quite classic. You can see that on MRI as well, but this is very, very nice with echocardiography. Next. IVC dilated without collapse. And what was the size? Can you see the size? 2.6. So this is if you're going to look at somebody before and after surgery or anti-inflammatories, this IVC is very important because it's a good judge whether your diuretics, your surgery, your anti-inflammatories really did anything. So this is a measure of RA pressure. Next. So this is a case of a classic constrictive progress. So the other point would be the hot septum. That's how we did this. So basically, the lateral wall is sort of stuck. The pericardial is sort of stuck to the myocardium. So the anterolateral septum is sort of decreased in mechanical function. Compared to the septum is still preserved, so that's why you call it hot septum versus the lateral wall. So the lateral wall is sort of tethered because of the pericardial myocardial dysfunction, and the septum is preserved. Any questions about constrictive pericarditis while we're waiting? Who's seen cases of constriction? Raise your hand. Okay. So normally, treated with surgery, but often if you catch it early with that MRI look, often you can go with anti-inflammatories. That's a newer concept, so-called transient constrictive pericarditis. Okay, so you see that the pink septum, as you can see here, the sort of pinker, and then compared to the hot septum. So you can see the septal bounce. Actually, Dr. Sengupta did a lot of the early work with strain and constriction restriction, and he also did AI with constriction restriction. And you can see, and then after the surgery, it reverses back. So actually, it could be strain reverses after you give the anti-inflammatories, or the surgery reverts back.